Type 2 familial dyslipidemia, familial hypercholesterolemia, particularly its genetics, lipid profile, clinical features, and complications. Question 1. Classic presentation of type 2A hypercholesterolemia. A 16-year-old boy presents with chest pain and a family history of early myocardial infarction. On exam, he has Achilles tendon thickening and corneal arcus. Labs show total cholesterol of 740 milligrams per deciliter, elevated LDL, and normal triglycerides. Which of the following is the most likely cause of his condition? A. ApoE mutation. B. LDL receptor deficiency. C. Lipoprotein lipase deficiency. D. ApoC2 deficiency. E. PCSK9 inhibitor mutation. Correct answer, B. LDL receptor deficiency. Explanation: this is familial hypercholesterolemia type 2A, an autosomal dominant disorder caused by absent or defective LDL receptors, or defective ApoB100. It presents with very high LDL, tendon xanthomas, corneal arcus, and early MI, especially in homozygotes. Question 2. Risk and lab findings in heterozygotes. Which of the following best describes the expected lipid profile and associated risk in a heterozygote for familial hypercholesterolemia, type 2A? A. Cholesterol 700 mg per deciliter, low MI risk. B. Triglycerides 1,000 mg per deciliter, pancreatitis risk. C. LDL 300 mg per deciliter, high risk of early coronary artery disease. D. HDL 20 mg per deciliter, risk of peripheral neuropathy. E. Total cholesterol 200 mg per deciliter, no increased cardiovascular. Correct answer, C. LDL 300 mg per deciliter, high risk of early coronary artery disease. Explanation: heterozygotes for familial hypercholesterolemia typically have LDL levels 300 mg per deciliter with normal triglycerides. They are at high risk for premature atherosclerosis and myocardial infarction, often occurring before age 20. Type 2B familial dyslipidemia, familial combined hyperlipidemia, which involves elevated LDL, cholesterol, and VLDL levels. Question 1. Lipid profile and risk in type 2B. A 30-year-old man is found to have elevated total cholesterol and triglycerides on routine screening. Fasting lipid panel reveals elevated LDL and VLDL levels. He has a strong family history of premature coronary artery disease. What is the most likely diagnosis? A. Type 1 hyperchylomicronemia. B. Type 2A familial hypercholesterolemia. C. Type 2 familial combined hyperlipidemia. D. Type 3 dyspeptidylipoproteinemia. E. Type 4 hypertriglyceridemia. Correct answer, C. Type 2B familial combined hyperlipidemia. Explanation: Type 2B is characterized by increased LDL and VLDL, leading to elevated cholesterol and triglycerides. It is the most common familial dyslipidemia, autosomal dominant, and associated with premature atherosclerosis. Question 2. Key difference from type 2A? Which of the following findings distinguishes type 2B familial dyslipidemia from type 2A? A. Elevated HDL. B. Normal triglycerides. C. Elevated VLDL and triglycerides. D. Presence of eruptive xanthomas. E. Extremely low cholesterol. Correct answer, C. Elevated VLDL and triglycerides. Explanation: both type 2A and 2B show elevated LDL and cholesterol, but type 2B also has elevated VLDL and triglycerides due to increased production of ApoB-containing lipoproteins, which distinguishes it from type 2A.